Hi everyone, and welcome to today's Physician Resource Center educational webinar on the Scripps Health Hospice program. Please note that all attendees are muted to avoid any background noise or interference during the presentation. At the end of the webinar, we'll allow for questions to be asked. You may submit your questions by using the GoToWebinar interface. Make sure also, if you'd like to raise your hand, we'll just direct you again to ask the question because we won't be unmuting any of the audio today. Today's presenter is Dr. Timothy Corbin. Dr. Corbin is board certified internal medicine and hospice and palliative care medicine. He did his residency as chief resident year at Scripps Mercy Hospital. He's had extensive experience with hospice and palliative care since 1998. He began the Scripps Encinitas Hospital Palliative Care Program in 2008 and helped with the implementation and development of Scripps Hospice earlier this year. He currently serves as Medical Director of Hospice and Palliative Care Services for Scripps Health. Welcome, Dr. Corbin, and thank you very much for being our guest host today.
Thank you. Welcome, everybody, and it's good to be on the line and to kind of share a little bit about Scripps Hospice. I think what I tried to do is focus on kind of three areas today. One will be just give you a little background on the implementation of Scripps Hospice and kind of where we stand today. And then I wanted to talk a little bit about kind of the update in the state of the hospice Medicare benefit. And my screen, I'm losing my screen for you, sorry. And lastly, talk a little bit about some billing factors for billing for services provided to hospice patients when you're not directly hired or contracted for the hospice, which I think is applicable to many physician offices and primary care physicians or specialists that may see hospice patients. So the story began for Scripps Hospice a little bit, as some of you may know, when San Diego Hospice began having some difficulties, and it looked like they were going to ultimately close as a hospice. And being a huge provider in the San Diego County and have had long roots and within our community, and has really had been a leader in our community and even nationally within hospice and palliative care. The discussion at that time for our patients within Scripps was what could we do as an organization to support our patients and provide hospice levels of care, and would it make sense for Scripps Health to get into the arena of hospice care? And I think when we looked at it from a Scripps Health vision, in my opinion, some of the factors was that it was a great way to continue the continuity of care and services that we provide within Scripps Health. So we have the ability to integrate care throughout the continuum of patients' lives, and not only early in patients' lives and treating their diseases and preventive care and treating acute illness, but even when patients began to have more terminal illness or end of life, we could continue to serve them under the umbrella of Scripps Health. And also very much aligned with Scripps' mission statement and our vision statement about what we do as an organization, and serving our community, serving the medical needs of our community. A couple examples of that is our pediatric program. When it looked like San Diego Hospice was not going to survive further, there was a pediatric program that really did not have a lot of other choices for these kids to go to support their needs. And one of the early decisions was that we had to develop a pediatric program that would enable these kids to have some choice for hospice care. And also there was a fellowship program that San Diego Hospice ran that many of you know about, and they had 10 fellows that were halfway through their year that had really wanted to become specialized in hospice palliative care medicine, and their fellowship was threatened, and the ability to take on a fellowship program within Scripps so that these fellows could finish their fellowship training, I think was a great thing for Scripps Health to be able to do. And in the future, looking to continue in a fellowship program that will train physicians within a specialty of medicine that is severely understaffed, and there will be a huge need for palliative care and hospice physicians in the future. And it's also about, as I mentioned, integrating medical care. So kind of looking at home-based services with home health, developing palliative care home-based services, as well as hospice care, and really being able to match the level of care that a patient requires with the level of service that's provided. Diane Meyer, a leader within palliative care, has always showed a slide that says palliative care is about matching patients' level of care with the medical services provided with the patient's desire for level of medical care and what their goals of care are. And that kind of enables us with all of those base therapies to really place the patient in the model of care that is best in line with what their wishes and goals are. So our story began back in February when we decided to get in the hospice and realized that to obtain our own license was going to be a very long process. And it just so happened about that time that Horizon Hospice decided they were looking to sell as an organization. They're a very small hospice based in Poway. They had approximately 25 patients on service at that time. They were the 13th hospice in the Southern California area. Long-standing hospice, had a great track record of care, but very small. And what happened is we basically took over them in a purchase where it was just a straight stock purchase, and we acquired assets. We acquired their hospice license, their Medicare certification, and a few limited hard assets, and had kind of a consulting agreement with them. And with that set the stage for us to be able to begin to provide hospice care within Scripps under the umbrella of Horizon Hospice. Since that time, we've now converted the name to Scripps Hospice. We also converted from a for-profit to a nonprofit status. And so this is a picture of our work board at the time, and it basically was a very, at this time we decided to take over Horizon Hospice was about the time that San Diego Hospice announced that they were going to have to close their doors and that patients were being given choices of other hospices, and we expected a large, patient volume to need new hospice, as well as lots of staff with San Diego Hospice organization that were going to be out of jobs looking to be rehired at other hospice organizations for those that wanted to continue. And so this picture was just showing how many patients a day we were bringing over and the patients that chose to come on to the Horizon Scripps Hospice, and it was a very rapid evolution. We brought on about 135 FTEs, and it was happened very quickly. So we developed a hospice under Scripps Hospice, and I think to focus on the physician piece of it a little bit is, I think one thing is that we've been somewhat physician driven in the fact that we've had hired physicians that are certified in hospice and palliative care to be integrated into our development, into our processes, into the care that we provide. So currently we have 10 board-certified hospice and palliative care physicians that are hired in a medical group that serves the hospice, including myself. And we have also, in addition to that, 2 nurse practitioners. And this medical group serves not only the palliative care consult service at 4 of the 5 Scripps Hospital campuses, but also serves the home care, serving our hospice patients. And I think we've been involved in the processes such as the interdisciplinary group meetings are run by our core of physicians. We have utilization review type meetings where the physicians are involved looking at processes and care of our patients. We have operations supervisory meetings where physicians are present. So we've really integrated physicians into our care model, which is unique compared to some other hospices. An example is that we will see patients if we are asked to be primary physician or the attending of record within 5 days of admission. If we're asked to be a consultant and to consult on the patient, we will see them within 10 days of admission, and that's kind of our farthest out time. Often we're seeing them within the first day or 2 of admission. And of course, then we'll follow up and see them based on their medical necessity, but we have our active physicians seeing patients routinely. We have a medical director that's assigned to North San Diego County, a physician that covers Central San Diego County, and one that serves South San Diego County. And those are core hospice physicians, and then they are cross-covered by the other physicians and the palliative care docs from the hospitals from a call structure. So we also have a call structure 24 hours, 7 days a week, where we have a physician, one of our core physicians is on call to address any needs that come up and are available to do visits. And of course, we're actively involved in certification of terminal illness, which from a Medicare standpoint is evolving and changing and takes a certain amount of expertise to do these well and to do these the right way. And of course, the face-to-face recertification visits that have been required now for a while are required to be done by hospice physicians or nurse practitioners that are hired by the hospice. So today our coverage is throughout San Diego County, and in fact Horizon Hospice covered really far east county, so even Borrego Springs. So we've had some patients kind of way out in some remote areas. So we have a pretty large capture area. Our current census is about 175 patients. We've been as high as about 205. And we really have capacity for growth and have an expectation that we'll continue to grow. Again, we have board-certified hospice and palliative care physicians, which are not only doing the home-based hospice care, but also will be integrating into doing home-based and hospital-based palliative care, which will really help with the continuum of care for those patients who aren't quite ready for hospice or who patients improve and no longer qualify for hospice services. We have a pediatric program. Dr. Kimberly Bauer is our medical director, and it's been a really good upstart program and has been consistent, and we'll continue to develop that program and working with Children's Hospital to continue to develop out the program. And then our fellowship program, I was very proud of the fact that we were enabled the 10 fellows to graduate from our fellowship program this last year, and we're dark this year that we don't have fellows for this coming academic year, but our hope is that the following year we'll have maybe up to 4 fellows that can work within our organization and continue to train doctors in fellowship within palliative and hospice medicine. Scripps Hospice, the Hillcrest property from San Diego Hospice, many of you know, is a beautiful facility in Hillcrest, which had 24 beds, which under San Diego Hospice was licensed for general inpatient care. We have acquired that property through the bankruptcy courts, and Scripps purchased this property. We actually had an opening walkthrough initially last evening, actually, and the anticipation is that that property will open sometime in the spring, and that'll give us the ability to have a number of beds and administrative offices, which will be our focus and our center point for our hospice. Scripps is going to long lengths to preserve the architecture and integrity of the out property. There's many plaques and dedications to patients who have been there before, and it's a really, really special place. And so it's nice that we're going to have that property and continue to see patients there. In what that property was meant to, in donation by Joan Kroc, was to be a property for hospice patients, and we'll be able to continue that. So I'd like to spend some time on the hospice regulatory update. Basically, Medicare, with their final rule in 2013, has come out with some newer statements on some guidelines that affect the way we practice hospice care. And I think it's just important for physicians and healthcare providers outside of hospice to kind of understand what is our requirements as hospice physicians and hospice organizations to ensure that we're meeting the guidelines. Medicare hospice benefit is a mandate, really, and there's not just for patients necessarily who are at the end of life, but they have to meet certain eligibility. So they have to meet these eligibility requirements, or else they cannot be on hospice service, or at least you can't bill Medicare for the hospice services you're providing. One of the statements relates around related and unrelated conditions, and it's an important concept to know is you see patients, whether you're treating conditions that are related to their terminal illness or whether they're unrelated. And the statement from Medicare states that it's their general view that hospices are required to provide virtually all the care that is needed by terminally ill patients. Therefore, unless there is clear evidence that a condition is unrelated to the terminal prognosis, all services would be considered related. It is also the responsibility of the hospice physician to document why a patient's medical needs would be unrelated to the terminal illness and prognosis. So when hospices were surveyed, about 87% of hospices were putting one diagnosis down as the terminal condition. For example, congestive heart failure, whereas in many patients there are multiple conditions that are contributing to someone's dying process. So they may have congestive heart failure, but perhaps they also have advanced renal disease and advanced COPD. Medicare's expectation is that you would say all three of those, if they're related to the terminal illness, would be checked. And that's important because hospice is required to pay for all care as it relates to their diagnosis. So, for example, the medications that are related to congestive heart failure would be required to be covered by the hospice. But if you check that the other related conditions, such as COPD and the renal disease is related, medications treating those disease processes would also have to be covered by the hospice. So as we're admitting patients on hospice and as we're caring for them, we really have to be clear, what the reason is this patient perhaps is dying. And having that conversation with the primary doctor or the physicians who really know the patient well is important to get that information so that we can document accurately the state of the patient. We are able to change that as things go along, but it's just important to have an appreciation for that. So the Medicare hospice benefit requires hospice to cover all palliative care related to the terminal illness and related conditions. And again, all services considered related unless a hospice physician can document why a patient's medical needs would be unrelated to the terminal prognosis. The relatedness is really the responsibility of the hospice medical director in collaboration with the interdisciplinary team or interdisciplinary group in the plan of care. So again, it's just want everybody to have an appreciation of that process. Another change is that in May, they came out saying that really we should not be using as the primary diagnosis debility or adult failure to thrive. And this should not be used as the principal diagnosis on a claim form. So we all know there's patients who are elderly who just seem to just not be surviving. They're not eating, they're getting weaker, and they're just really slowly dying, and we put them on hospice under debility or adult failure to thrive. Medicare really wants us to paint a picture and be more specific as to why a patient may be dying. And so instead of just going by certain criteria, like LCDs we call them, related to debility or adult failure to thrive, they want us to look at those prognostic indicators, but they want us to paint a bigger picture than just saying the patient has debility and failure to thrive. They want to know more specifics. So for example, if a patient is 90 years old and has severe osteoporosis and falls and has compression fractures, and because of the pain, now they're more bedbound, they're not eating, they're not tolerating the pain meds, and they're just really declining. We probably used to put just adult failure to thrive or debility on a patient like that. Probably more specific now would be to put that they're dying because of compression fractures, osteoporosis, and then a secondary or tertiary diagnosis could be debility or adult failure to thrive. So the reason that Medicare changed this is because 20% of Medicare hospice populations were put under the diagnosis of debility or adult failure to thrive. They also tended to have a longer length of stay on hospice, so it's really Medicare's way of kind of trying to get hospices to be more specific as to what's going on, and they want to ensure that the hospice providers are treating all the conditions related to the terminal prognosis, not just one kind of catch-all phrase, if you will. So what I encourage us to do, and that would relate to doctors who are the attending of record who see patients and see them in their notes, is to really paint the picture of the patient. And it's not only the primary illness as it's being treated, and their comorbid conditions are very important to paint a picture that, they may not be dying just of Alzheimer's disease, but because they have advanced COPD and moderate congestive heart failure and moderate renal disease, all of those add up to being at very high risk a patient dying within a short period of time, or maybe even being terminal already. So secondary conditions are really important, documenting their nutritional status, their functional rate of decline, cognitive function, infections, and probably more than ever before, we're checking labs in patients to try to help document that they're also declining, such as documenting their basic electrolytes and renal function. Are they more anemic? Checking albumin levels to see their nutritional status. All of that really helps to paint that picture. Lastly, I want to just transition into a little bit about physician billing for the hospice patient services, because I think there's a lot of confusion out there, and I think sometimes physicians, particularly primaries that are following patients, are sometimes reluctant to pass patients to hospice because they feel like when they see them they won't get reimbursed anymore, and that really shouldn't be the case. We should still be reimbursed for the services we provide for patients. So I'd like to talk about the ways you can do that. And there's really, when you see a hospice patient, there's kind of 2 or 3 different scenarios. One is that if you're the medical director of a hospice, that means you're under a contractual relationship with that hospice to provide services for patients. As a medical director, such as myself, when I see a patient, the hospice bills Medicare Part A for my services as they relate to hospice. So when I see a patient and they're on hospice for congestive heart failure, if I see them for signs and symptoms related to congestive heart failure, the hospice bills on my behalf Part A Medicare. If I see the patient as the medical director for an unrelated condition, such as, let's say, their diabetes, which I don't feel relates to their terminal illness, I can still bill for that as the medical director, but I have to bill Part B Medicare, and I have to, and then it would not be related to their terminal illness. So I would not bill through the hospice Part A. For community physicians, I want to focus really on when you're not a contracted medical director, so you don't have a contractual relationship with the hospice to provide continuous care for patients on the hospice, then you'd be considered a non-medical director. Under that umbrella, you can either be a non-medical director and be the attending of record, which means basically the hospice identifies you as the doctor primarily responsible for that patient's care, and then you are the attending of record, or we could say their primary doctor while they're on hospice. Or you can be a non-medical director and not be the attending of record. So maybe they see, maybe their oncologist is the attending of record, but as the primary care doctor, they come to your office for some reason and you have to see them. In that case, you're not a medical director for the hospice and you're not the attending of record. So can you get reimbursed for that visit? So let's talk about 2 modifiers. There's 2 modifiers you need to use when you bill for patients. It's the GV modifier and the other modifier is GW. GV modifier is used by the non-medical director, hospice attending of record, when billing Medicare B for any care provided to the patient. It does not matter if the treatment is related or unrelated to the terminal condition. This code identifies that the physician as a hospice attending of record that is not the patient's hospice medical director and allows routine Medicare B billing. So by using modifier GV, you're telling Medicare that I am the attending of record, I'm not a contracted physician, and I can bill Part B for diagnosis related to their hospice and unrelated to their terminal condition. The other modifier is GW, and GW, regardless of the provider, care that is not related to the terminal illness is billed as usual through Medicare B, even though the patient is receiving hospice care. So GW basically tells Medicare that you're seeing this patient, but it's for an unrelated diagnosis. It's not related to their terminal illness. If you don't use that modifier, Medicare will look at it as, oh, they're on hospice Medicare benefit, and they'll deny the bill. So you need to put the modifier to alert Medicare that you are seeing them for unrelated conditions. So if you are not a medical director and you're the attending of record, so you're listed as the attending of record for the hospice patient, you can bill professional services as you would bill normally for patients, except for 3 exceptions, that if there's care related to the hospice diagnosis, you should use the GV modifier, which is, again, telling Medicare that the treatment is that you are the attending of record of the patient on hospice, and it'll allow you to get reimbursed through Medicare Part B. If you're seeing a patient and the care is not related to hospice diagnosis, you should use the GV modifier, but also the GW modifier, which is telling Medicare that you are the attending of record, but you're seeing a patient for an unrelated terminal diagnosis. Any technical services that you provide, such as labs or radiographic studies or any procedures, are required to be paid for by the hospice if those procedures and labs are related to their terminal condition, and those would need approval by the hospice before those things are drawn. are performed, because all costs related to the terminal diagnosis must be paid by the hospice. The last one is, if you're a non-medical director and you're not the attending of record, you can bill for Medicare as usual if the visit is unrelated to the hospice diagnosis. Again, you want to use the modifier GW, which would identify you as seeing them for an unrelated condition. If you're seeing the patient for a related hospice condition and you are not the attending of record, then you cannot bill. Medicare will not pay for that service. In that case, you would really be considered a consultant, and you would have to have a consultant contract with the hospice, and the hospice would bill, would basically do a pass-through and pay you for your services based on what you set up in the contract. So if you're not the attending of record and you see a patient, so an example would be if you have a patient with lung cancer and they go and see their oncologist who's cared for them, and the oncologist is chosen as the attending of record, but the patient comes to your office to see you. So you're not the attending of record, and you're not a contracted medical director. If you treat anything related to their lung cancer, you will not get reimbursed by Medicare. If you see them for an unrelated condition like a rash or maybe diabetes that's unrelated to their lung cancer, you would bill Medicare like you normally would, but again, just use the modifier GW. The last, real quick, care site overplan can be billed. If you're a non-medical director and you're the attending of record, you can bill for care plan oversight. There's some requirements to that you must not be the medical director for the hospice. You have to document in the chart that you've spent over 30 minutes in the calendar month in care plan oversight activities, and the physician must have billed for a face-to-face contact with the patient in the 6 months prior to billing for the care plan oversight. And only one physician can bill for this care plan oversight, and it must be the physician that signs for the plan of care. And the activities that are acceptable are varied, such as activities related to coordination of care, chart review, making decisions about the patient's care, phone calls to family or surrogate decision makers or other physicians, really anything related to the care of that patient. If you can just document those activities and it's more than 30 minutes within the calendar month, you can bill for care plan oversight. The bill for hospice is 99378, and again, you have to bill it with the HCPCS G code as it's listed there on the slide. And again, you can bill each benefit period. So at least it's possible to get some reimbursement for the time you spend with hospice patients. That's our Scripps Hospice phone number and my email if I can ever be of service to you or answer further questions. I'll open up for general questions if there are any.
Thank you very much, Dr. Corbin. Yes, for everybody that's attending right now, you can type in your questions using the GoToWebinar interface. The questions will come through and we'll read them out loud, and then Dr. Corbin can answer them. I do have a question that was passed along, which I'll start off with here. What percentage of medical care the hospice provides is reimbursed by Medicare versus other payers?
That's a good question. So I can't give you an exact number for us at this time. I think the majority of patients are Medicare patients, but I would guess that probably 60 to 70% of our patients are probably on the Medicare hospice benefit, which opens the question, when there's private insurances, there's going to be some variation in the care and some of the requirements, but if you follow the hospice Medicare benefit guidelines, you're probably going to be pretty consistent and in line with the other insurances. But there is some variation in what the private insurances will pay, and it's a matter of looking at that insurance on the front end and trying to come up with a care plan of what they're willing to cover and what they're not willing to cover. And it does vary pretty broadly depending on the type of insurance the patient has.
Okay, well, thank you very much for that. Doesn't seem to have any other questions that's flown through right now, but if the email address has been documented, I'm sure you're open to receive questions over email, Dr. Corbin?
Yeah, always open to answer questions if I can, and be happy to do so.
Well, great. Well, thank you very much for preparing this presentation today. It's been very comprehensive. And again, everybody that's attended, we'll go ahead and share this out. The slides for the presentation will be shared tomorrow. The video for the presentation will be available next week. So thank you again, Dr. Corbin, for your time today.
You're welcome. It's my pleasure. Thank you.
Have a good day, everyone. Bye-bye.
Bye-bye.